Good afternoon, everyone, and welcome to Quality Payment Program 2023 Year 7 Final Rule Highlights. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare services. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. And then just a couple housekeeping items before we get started here today. To be sure we have enough time to cover the content, we will not have a Q&A session at the end of this webinar. We do have a slide at the end of the presentation that's going to provide direct contact information to advisors. And then you can also email any questions to our RAC email. So please send us any questions you may have, and we look forward to answering them. And then we will be sending out the slides following the webinar. So you will have that contact information as well as any resources that we review today. Today's presenters are myself, Alicia Anderson, and my colleagues Robin Kernel and Jessica Elliott. And today we're going to review changes from the final rule made to MIPS as well as MVPs. And then we're also going to look at those impactful changes made to advanced APMs and Medicare shared saving programs. And then we'll wrap up with changes from the final rule that may sit outside of the quality payment program, but could be impactful for your practice. And then we'll get started here today with those changes to traditional MIPS. So this slide here is just going to show some background information regarding the physician fee schedule final rule and include those relevant citations. It's also going to include hyperlinks to the final rule itself, as well as some fact sheets. And those fact sheets are going to be really useful if you want to dig a little deeper into the final rule. They do a great job at kind of condensing that information for you. And then for thresholds and category weights. So there were no changes made to the category weights or the scoring thresholds themselves for 2023. So we can see the weights remained here the same, with your quality and cost aligned at 30%, your promoting interoperability at 25%, and your improvement activities at 15%. And then there were also no changes made to the scoring thresholds. So if you were to score between 0 and 18.75 points, you would be subjected to that 9% negative payment adjustment. And then if you scored between 18.76 and 74.99 points, you would be eligible for a negative payment adjustment up to 9%. And what that payment adjustment really is going to look like is going to be dependent kind of where you fall in that range there. And then for 2023, 75 points is going to remain that threshold. So there you would receive a neutral payment adjustment. And then to receive a positive payment adjustment in 2023, you would need to score between 76 and 100 points. And again, what exactly that score is going to be is going to kind of be dependent where you fall in that range. And then the one thing we really do want to point out here is going to be the removal of that exceptional performers bonus. So that bonus was that extra pot of money that CMS had set aside to kind of reward those high performing practices. With that being removed, the only positive payment adjustments are going to come through that budget neutral portion of the program. So that's kind of going to impact what we see those positive payment adjustments look like. And then for eligibility and scoring, CMS has maintained the small practice promoting interoperability reweight for program year 2023. So this will be automatically applied as it was in 2022. And then since this is kind of a common reweighting scenario, we do have here what that would look like. So if you took that reweight, your quality would shift up to 40%, your improvement activities would shift up to 30%, and then your cost would remain the same at 30%. CMS has, however, removed the automatic reweight for 4 clinician types. And those clinician types are going to be your NPs, your PAs, your CRNAs, and your CNSs. So these eligible clinician types would need to apply for a PI hardship in 2023 if you cannot attest to promoting interoperability. And then another change for this year is that CMS is applying the complex patient bonus to both your facility-based MIPS eligible clinicians and your virtual groups. So this will be the first year that they were eligible for that. And so for the quality category, CMS has added 9 new quality measures. One of those is an administrative claims measure. There's 1 composite measure, 5 high priority measures, and then 2 new patient reported outcome measures. The CMS has removed 11 measures and retained 2 for MVP only. So the ones we really want to point out for you is going to be your diabetes, medical attention to nephropathy. That measure is completely going away. So if it's one you used, want to start looking for a backup measure. And then your preventative care and screening influenza immunization and your pneumococcal vaccination status for older adults. Those 2 measures have been removed from traditional MIPS, but they will remain available for MVPs. So if you're participating in traditional MIPS, you would not be able to use these. However, if they are part of the menu of an MVP in which you're participating, they would remain available to you. And then for data completeness, CMS has retained 70% data completeness for 2023. But as we move forward into 24 and 2025, that is going to increase up to 75%. So we can start preparing for that now. And then for measure scoring, your measures that are reliably scored against a benchmark. So if you meet the data completeness and case minimums for these measures, you will now earn between 1 and 10 points. And this is going to be impactful as we previously had that 3-point floor. So the lowest score you earned would have been those 3 points. And then starting in 2023, you could potentially see that score of 1 point for a measure. And now if a measure does not have a reliable benchmark, so even if you meet the data completeness and the case minimum for these measures, you will receive 0 points in 2023. Small practices will, however, continue to receive 3 points in this circumstance. So we really do recommend having a few backup measures in place just in case if a benchmark is removed during the performance year. And then measures where you do not meet the case minimum criteria. So you don't meet the case minimum criteria, you have less than 20 patients in your denominator, you will receive 0 points. And then here as well, small practices will continue to earn 3 points in this circumstance. And then you're promoting interoperability category. So this slide here is going to show the measures for each objective and then their corresponding potential points. And then just as a reminder, you can score up to 100 raw points in this category. And the main things we really want to point out for promoting interoperability. In your e-prescribing objective, the query of the Prescription Drug Monitoring Program, or the PDMP here in Kentucky, CASPR. This was previously an opportunity to receive 10 bonus points, but starting in 2023, this is going to be a required measure for that objective. And then the next big change here is going to be in the Health Information Exchange objective. And that's going to be the addition of participation in TEFCA, so your Trusted Exchange Framework Common Agreement. And the goal here is really just to establish a universal floor for interoperability across the country. So previously, you had the 2 options to satisfy this objective. So you could support electronic referral loops by sending and receiving for 15 points each. And then this option was performance-based. Or you could have had a bidirectional exchange, so through KHI, and then with that option, you would receive your full 30 points. So TEFCA is going to be more similar to that bidirectional exchange. You will receive the full 30 points, and it would not be a performance-based measure. And then there are really no changes to the provider to patient exchange objective. And then for public health and clinical data exchange, required for 2023 is still going to be your immunization registry reporting and your electronic case reporting. And then you can earn those bonus points by participating in public health registry reporting, clinical data registry reporting, or syndromic surveillance reporting. And then cost category updates. So CMS has added cost improvement scoring for 2023. So with this, you can earn a maximum of a 1% point out of 100, and that's going to be added to your cost score. And then CMS will determine this improvement scoring by evaluating cost measures over 2 consecutive years. So if you're scored on the same measures for those 2 consecutive years and you show a statistically significant improvement, you would be eligible for the improvement scoring. And then what that score will look like is really going to be determined based on how many measures you were consistently evaluated on, and then how many that you were evaluated on, how many of those did show an improvement. And then just to note, you will not see this in 2022 scoring, as cost was not calculated for 2021. And then the only other update in this category is just going to be an update to the operational list of care episodes and patient condition groups and codes. So CMS is adding Medicare spending per beneficiary clinician cost measure as a care episode group. And this is not going to impact your scoring or your case minimums or anything like that. It's really just a classification change. And then our last category is going to be the improvement activities updates. So CMS has added 4 new improvement activities, 2 that are high weighted and 2 that are medium weighted. They have modified 5 existing activities. So if you're participating in any of these modified activities, you're really going to want to start reviewing that validation and just make sure that when the time comes to start your 90-day time frame, you're collecting the correct evidence to meet the activity. And then CMS has also removed 6 activities. And the main one we really want to point out here is going to be the consultation of the PBMP. Since this is now required for promoting interoperability, it's no longer going to be an opportunity under improvement activities. We know that this was a very popular improvement activity, so if you're participating in this, we would recommend looking through the improvement activities inventory early to kind of find a replacement activity and find one that matches the work your practice is already doing. And then the other update to improvement activities is for MIPS APMs. So if you're participating in a MIPS APM, you would receive full credit for improvement activities. If you were to submit any additional activities, these would not be scored. And then this is really just to limit unintentional improvement activity submissions if they were included in your QRDA3 file. Well, thank you. And now I'm going to pass it over to Jessica for changes to MVPs.
Thank you so much, Alicia. And thank you all so much again for joining us today. I'm going to talk with you a little bit about MVPs. 2023 is now the first year that MVP reporting is going to be available for practices and for eligible clinicians out there. This window for MVPs actually to be able to attest and register for a particular pathway is going to be going live sometime here in April, and that registration window will remain through November of 2023. Now, just to kind of level set, and because this is a brand new track, even though CMS has been talking about MVPs and had finalized this particular track in subsequent legislation over the last few years, just want to spend just a few minutes just, again, kind of reviewing why this track is in place. And really, MVPs have been created to help move the process along of transitioning clinicians and groups who've been participating in traditional MIPS into MVP pathways, these MIPS value pathways, with a focus of improving the value of care that's being delivered to help reduce burden, and then also to be able to provide patients with more of a choice around selecting their clinicians, because there will be more specific clinician level or specialty level data provided with this mechanism of reporting. CMS really also looks as this, as MVPs, as really being a bridge to APMs. And by reporting MVPs, it aligns you with a central or very focused cost measures, improvement activities, and quality measures that align with that particular MVP. As universal measures, though, that go across all MVPs, every MVP will have a set of population health-based measures that you would actually select at the time of registration. And you would also have promoting interoperability measures. So all of the different categories that Alicia talked about, the cost, quality, improvement activities, and promoting interoperability of traditional MIPS, anything that gets finalized in the legislation for traditional MIPS for those categories, those same parameters are going to apply to MVPs. So everything that she talked about is going to apply for 2023 MVP performance. However, promoting interoperability is one of those that's a foundational measure that's going to be required for all MVPs unless you have some type of a special status or designation that allows for a reweighting of that category. But otherwise, you pick your pathway and you perform in it. And so I'm going to switch us over to look at the finalized MVPs. So these are the 12 MVPs that CMS has put into effect for 2023. The light blue ones are one that have been finalized in previous legislation. The bright green ones are ones that are brand new for 2023 and that were just recently finalized for the program. So these different MVPs are going to span a couple different, several different actually disciplines. So there are going to be some primary care related MVPs looking at chronic disease management and promoting wellness. There are also, but MVPs also are creating a specialty track as well and making it a more direct pathway for specialists and those types of clinicians to be able to have more aligned measures to go with the type of patients that they see and the care that they provide. So we have some neurology-based ones. We also have a cancer-based one, ESRD, emergency medicine is represented in this measure set, as well as anesthesia and heart disease and stroke. And we also have an orthopedic one that is focused on lower extremity, so hip and knee replacements as well. We do anticipate over the coming years, at least through 2027, to have more, every single year, more and more MIPS value pathways finalized to allow for greater subspecialty reporting for clinicians so that, again, patients have that transparency of quality performance for their clinicians so that they do have that empowerment and that decision making in the physician compare tools to be able to select those clinicians that they would like to receive care from. Now, for 2023, again, this is a brand new program. This is the first year that you'd be able to report in this MVP track. And again, it is voluntary reporting for MVPs in 2023. We kind of look at this as this is your opportunity if you're interested in exploring a particular MVP pathway for your clinicians, for your tax ID. This year is probably the year to kind of dip your toe in the water. We have up there that it says no fault registration or no fault scoring. And what that really means is that if you prepare and do a traditional MIPS submission, if you're for your required clinicians or your eligible clinicians who are required to submit for the program, you can submit that, but then you can also test the waters with submitting an MVP. So you can actually submit both. And for 2023, CMS has said that they will take whichever is the higher of the score and apply that to your payment adjustment. And so you have that opportunity to have a little bit less risk involved whenever you're registering for and signing up for an MVP. Something else to keep in mind too, if you do decide to register for an MVP in April, and perhaps you change your mind and decide that you either no longer want to report that particular MVP and you'd like to report something else. So maybe you're going from the wellness MVP over to the chronic disease MVP. If you don't do a submission for that first MVP you registered for, that's okay. If you don't submit this year for an MVP that you've registered, you will not be penalized for it. And same thing as if you completely change your mind and you don't submit data at all, but you just continue to do traditional MIPS for 23, they will just use your MIPS score. They will not take into account the registered MVP that does not have data attached to it. Additionally, just as an FYI, the information that you do submit, if you do decide to voluntarily report this year, it will be publicly reported and will be available. So your patients and the public will have access to your performance through that MVP pathway. Now, there's a couple different levels in which you can report on MVPs. And some of them are, similar to what we are used to through traditional MIPS. So we have MVP participant or an eligible clinician. So we can submit an MVP at that individual provider level, just like how we can with traditional MIPS. You can also have a couple different group reporting options. So group reporting options are going to be a multi-specialty group, a single specialty group, or forming subgroups within a tax ID. So multi-specialty groups, this is a very limited participation window that CMS is allowing you if you are a tax ID that have multiple different types of clinicians reporting under one tax ID. As long as you can find a MIPS value pathway that is reflective of all of your clinicians, then you would be able to report this as a multi-specialty group through 2023, 2024, and 2025. However, starting in 26, multi-specialty group reporting will go away. And from there, you'll have two other group reporting options if you choose to continue to report as a group. You can either be identified as a single specialty group. So that means that it is a group consisting of one specialty type, one type of clinician. And that is actually what is defined in the National Provider and Plan Enumeration System, or NPES, is where you can kind of look up how your providers are classified. But CMS is ultimately going to be looking through PACOS to make that determination and ultimately look at your Part B, your billing, how you're billing your patients. And they will have that designation identified. We anticipate that to be updated in the portal as well too. But however, you would report as a single specialty group if you just have one clinician type tied to that tax ID. Otherwise, you would need to report and break out into subgroups. And so CMS, again, they're really wanting to start digging down into more granular reporting. And so subgroup formation is going to be if you have multiple different types of providers. So perhaps you have neurology housed with orthopedics and perhaps primary care. And so you would need to actually form 3 subgroups based on the provider types that you have in order to, as a tax ID level, participate in MVPs moving forward. Now, CMS has not provided a specific timeline for the sunset of traditional MIPS. However, they have in the legislation have given a very strong indication that traditional MIPS is going to sunset. And so the 2 pathways to report for the quality payment program are looking to be through MIPS value pathways and through the APP. If you're a part of a MIPS APM or other type of alternative payment model. So that is something to keep in mind when you're starting to look at and test the waters for MVPs is how are you going to break out into reporting? How are you going to break out into groups? And what is your tax ID made up of? So that you can start having those conversations around what MVPs are going to be appropriate for you. There's a couple additional details that CMS did release with subgroup reporting for 2023. You are limited as an eligible clinician to only be found in the data for one subgroup within a tax ID. So as an eligible clinician, you can't participate in multiple subgroups. If your specialty kind of overlaps, you need to be able to pick one, and that would be where your data is found. So that's where I think being able to report and to be able to have your EHR or your registry be able to provide more specialized reporting for these subgroups is definitely going to be coming into play. CMS does have a determination period. They're looking at essentially what is the finalized snapshot for 2022. That's also the first snapshot for 2023 eligibility. So they're looking at If they meet the low volume threshold, so the $90,000 in Part B billing, 200 covered professional services, and 200 Medicare attributed beneficiaries at that individual clinician level, to see if they are going to be required to participate in traditional MIPS. And if you're required to participate in traditional MIPS, you have the option of being able to participate in an MVP this year. So that is something to consider as well. And then CMS has also made some additional clarifications around how subgroups would be scored. So around those universal population health-based measures and cost-based measures, if your group score is not able to be generated, you would receive an exclusion for those particular measures. Those would not count against you at that subgroup reporting level. If your group does apply and meet the thresholds for group scoring for those population health and cost measures, then you would receive that group score applied for that particular category. Now, let's transition over to talking about some changes with the APM performance pathway. So this is primarily for our folks in MIPS APMs, or perhaps you're an advanced alternative payment model, but you're not meeting QP status. You would participate in the APM track. Now, CMS has made a couple different updates to this particular track. They have settled on the growth factor for the ACO's historical benchmark, and they're actually using now a three-way blend. They're no longer using just the national and regional blend, but they're also incorporating the acceptable care prospective trend for that as well. So again, that is making that benchmark a little bit more realistic and achievable, and lowering that or taking into account some of the market a little bit more acutely than it has in the past as well. So something else that is new that applies both to the APP as well as advanced alternative payment models is that CMS is now allowing for a sliding scale of shared savings and shared losses. And so instead of having to meet the existing quality performance standard, they have created what's called an alternative per quality standard. So instead of having to meet the 30th percentile in your quality performance category to be able to receive your full risk, your full reward, you now only have to achieve up to the 10th percentile in those measures in order to receive some type of shared savings or to reduce your losses as well. So that again is another incentive that CMS is creating to help buffer some of the risk that's associated, and to help incentivize practices and clinicians to start investigating and looking into transitioning to MIPS APMs and then advanced alternative payment models. They have also finally set a permanent nominal risk standard to be 8%. That's what they've had the last couple years, and that is what they are deciding to stick with for this program. The minimum risk that you can have as a part of a risk-bearing model is going to be at 8%, and it can go up from there. They also made some limitations around those participating in a medical home model. They're just limiting the number of clinicians that can be a part of that medical home model APM, and limiting that to 50 clinicians. Something else that was just recently announced as a part of the Omnibus Act of 2023. We don't have this in the slide because this is literally very, very new that's come down the pike. But part of what was supposed to happen with 2023 for those participating in an advanced alternative payment model and those meeting the qualifying participant or QP status threshold was that you were to get, historically, they have received a 5% lump sum bonus annually as an incentive to participate in an advanced alternative payment model if you meet those beneficiary and billing thresholds for that advanced APM. Well, the legislation that was created with MACRA has been set to sunset that 5% lump sum bonus at the end of 22. Leaving a gap in 2023 where no qualifying participants in an APM would receive any type of bonus, And then starting in 2024, they would be on that annual update cycle for any type of an annual payment adjustment. And so with the 2023 Omnibus Act that was just passed through Congress, they have actually provided, instead of they provided a little bit of a bridge. So they're not renewing the 5% lump sum bonus for 23, but they are making available a 3.5% lump sum bonus for those folks who are meeting that QP threshold in an APM. So there will be a little bit of funds provided to bridge the gap until APM participants transition to that annual payment adjustment in 24. So that's some good news. One other thing I do want to mention here is Medicare shared savings. Now, technically, Medicare shared savings did sit outside the QPP portion of the PFS rule, but this is something that does impact the MIPS track as well as impacts just the overall participation of Medicare shared savings participants in those MIPS APMs. So something that they are providing for and have in part of that restructure of the program is around creating advanced investment payments. And so if you are a new ACO or you are risk bearing for the first time as an ACO, they are allowing an investment payment. Keep in mind, this is not an incentive payment. So this is something that you do have to pay back once you start having shared savings. It's actually at the first dollar of shared savings, you will actually pay CMS back that investment payment, or you'll start a repayment plan. But if you are a newly formed ACO or first-time risk-bearing, you'll receive a one-time lump sum payment of $250,000, as well as receiving 8 quarterly payments over the first 2 years of your payment arrangement. And that's going to be based on the medical complexity and the acuity of the patients that are a part of your beneficiary population. So essentially, they are encouraging MIPS APMs, those participating in a Medicare shared savings APM, so the track A's through track E's, to take on patients who are generally carry more risk because they're more medically complex. They are higher utilizers of service, and traditionally a lot of APM and ACO models exclude those patients. And so in an effort to improve equity and inclusivity, CMS has moved to this model to help incentivize those physician-based ACOs and MIPS APMs to reach out and to really to spread the Medicare shared savings and this MIPS APM model more widespread throughout the community. Again, they've set up some different limits and parameters around how you can spend those payments and that lump sum, and there is accountability and that requirement at first shared savings to start paying it back. They have also created some additional flexibility about how long you can stay in shared savings. Traditionally, you had a very limited amount of time in your first wave of that first agreement period that you signed that you can be in either track A or B before progressing to more increased risk. However, if you're a brand new ACO entity entering into MSSP, you can actually, the way they've changed the legislation is that you can actually stay in that track for up to 7 years. So you could be in track A or B for up to 7 years before you have to start taking any further additional downside risk. So again, that's another incentive that they are rolling out to increase the adoption of Medicare shared savings and APM models. Also, track E and the enhanced track of Medicare shared savings are now going to be considered advanced alternative payment models. So if you progress to E or the enhanced, which again is full risk, full reward, that you would be able to remain in there indefinitely. Track E, you always had to progress to the enhanced track, but now they're keeping that flexibility that you can do either or and maintain that APM status or the advanced APM status and those benefits around that particular track. So with that, I want to hand the presentation over to Robin Kernel, who will talk to us about some of the additional impacts outside of the QPP portion of the rule.
Thanks, Jessica and Alicia. So as Jessica just mentioned, we're going to talk about some things that impact providers and clinics outside of QPP. They were all published in that physician fee schedule. And so we want to make sure that we keep you up to date with anything that might impact you as well. So one of the things that was talked about is the e-prescribing for controlled substance update. This applies to providers who prescribe opioids or Schedule 2 through 4 controlled substances under the Part D program. CMS is in the past and other final rules and documents have indicated that they'll start monitoring how much of these controlled substance prescriptions are being ordered electronically versus a handwritten prescription. And then CMS was going to go so far as to issue out compliance letters and then at some point start indicating some fines or whatnot related to not being compliant. They continue to push that out. So currently that's been extended. So this year in 2023, you may start to receive some kind of compliance letter that indicates if you have ordered these controlled medications and you haven't met that 70% threshold, CMS is going to give you some indication. And right now they're not even pushing any kind of action towards that. They're just issuing the compliance letters. A lot of that comes from some of the waivers and such for the public health emergency related to COVID-19. So don't be surprised if you see some of these coming. Now, it's all those that are under Part D drugs. They also finalized the list of exceptions, and there was multiple exceptions to this. And so CMS took some time to update all of those exceptions. Some of those being obviously that there's not a pharmacy that receives electronic prescriptions within your prescribing area or geographic area. That's obviously getting harder and harder to meet around here, but it could be applicable in other states. When it comes to rural health clinics and FQHCs, CMS recognized that there are a couple of services that require some time spent coordinating outside of your visit time, and this being chronic pain management and treatment, and then the care management services for behavioral health conditions. So they issued 2 new HCPCS codes that's appropriate to those particular prescription or diagnosis groups. So they do, the one HCPCS code for chronic pain management does require an initial face-to-face visit for at least 30 minutes. And then any time spent outside of that time coordinating care or referrals and things of that nature, you can use the HCPCS codes and some of these G codes initiated here. And then again, for the behavioral health conditions, there is a 20-minute face-to-face time or sometimes spent with a psychologist or social worker each calendar month that's associated with that one. These codes can be payable alone or with other payable services after January 1st. So this is in effect now. So some significant telehealth takeaways. Jessica mentioned earlier the Omnibus Bill Act for 2023. That was just signed December 22nd, I think, 21st, 22nd. And like most bills through Congress and our legislation, lots of things get tacked in there outside of what the original plan was. And she mentioned the APM adjustment. Telehealth was also mentioned, actually quite extensively. But one of the things that was changed was this 151-day transition period that came about in the Consolidated Appropriations Act earlier in 2022. CMS has now extended all of these waivers that are going to go into effect on the ending of the public health emergency. These will now stay in effect through calendar year 2024. So I'm not exactly sure how extensive this is going to be. I'm still waiting on some more information coming down from our telehealth partners, but it is explicit that anything that was going to expire within the 151 day is now extended all the way into 2024. So, with that being said, it may make some things on this slide, it may negate a few things, I guess we can say. So a couple of things that I don't think will change is through the public health emergency, we issued a lot of temporary codes for telehealth services that are outside of what CMS has on their permanent list. And so those are listed as category 3 and 4. They are still considered temporary. As of the physician fee schedule release, CMS was not indicating that they would actually make any of those codes permanent, but at this point, I think we can safely say that whatever you've been using for telehealth coding, you can extend that through 2023 and into 2024. So if you're providing the service now by telehealth and you weren't prior to COVID, you can still continue to do that. This also allows for the patient's home to continue to be the originating site. At first, we didn't expect CMS to continue that, but I guess with this latest release in the omnibus bill that allows for the patient's home to be an originating site at least through 2024. Telehealth modifiers and place of service codes, those are available throughout the end of this year and in 24. And currently, it'll continue to delay that in-person requirement for mental health visits that are furnished by RHCs. Also within the physician final fee schedule that came out in November were some changes to colorectal cancer screenings. So essentially they're reducing the minimum age now to 45 years from 50. So Medicare will cover those who are in a younger population. Also including screening tests. So if folks have a stool-based screening test and it indicates that maybe they need a colonoscopy screening, CMS will continue to consider that as screening unless there are specimens obtained during that screening, then it becomes a diagnostic. But if there are none, then it'll remain a screening colonoscopy and reduce that Medicare beneficiary responsibility. And then CMS also indicated when it comes to the beneficiary cost sharing portion, they will over time reduce the amount that the beneficiary is responsible for. Now this is about a 7-year process. So for calendar years 23 through 26, beneficiaries are responsible for 15% of the cost, and then it'll drop to 10% and then 0 beginning in 2030. And one of the things that we like to talk about is what information is being published for public reporting for physicians and hospitals. The website that's used is now Care Compare, and you'll start seeing that telehealth indicators will be published with your data there so that consumers can see what providers offer services via telehealth. And then we'll start seeing more MIPS data submitted as well. If you remember when macro legislation was originally released, we talked about public reporting that it would be at least 2 years before we would start seeing any kind of MIPS data. So now we're seeing not only all of your MIPS data from the past 2 years, but we'll start seeing more volume and new measures associated with that as well. And then MVP data. So if you elect to participate this year in an MVP, we'll start seeing that being reported as well. So some top takeaways for the 2023 final rule that we felt as a team were pretty significant. These are really not in any kind of special order, but somewhat significant, I guess is how we called them out. Is the removal of the consultation of the prescription drug monitoring program as an improvement activity, but also it's been changed to required within the promoting interoperability category. So we felt like that was pretty significant. It's been a pretty easy one for folks to use for IA since Casper is required to be checked prior to prescribing an opioid. Pretty significant change with the complex bonus calculation. Folks kind of count on that to help improve their score. And now that we see that they're going to rank that a little bit more. And so you won't necessarily get that bonus unless you have patients that are meeting a specific criteria around that and be a higher condition code scaled. The loss of automatic reweights for physician assistants, nurse practitioners, CNS, and CRNA. We weren't surprised to see this, but it is somewhat significant. You know, your nurse practitioners have been participating in the Meaningful Use program for several years, but these other groups haven't. CRNAs don't necessarily place orders and such within your EMR, so it's a significant change for that group of individuals as well. So if included in your group or any of these clinicians, keep in mind that they're not automatically reweighted from the promoting interoperability category. We've got in here removal of key quality measures. That references back to the pneumonia and the influenza vaccination, 2 measures. Again, those are 2 measures that folks tend to score really well with quality metrics, and the fact that they're being removed from traditional MIPS and only being used under the APM models, we felt like was pretty significant for folks. Maintaining the 75-point final MIPS score was what we felt was good in Medicare's favor. Folks, there's so many other changes to the program within 22 and 23 that it's going to be more difficult for folks to meet that required threshold. So we were glad to see that at least stayed the same. One of the things that seems to be causing some heartache for folks is this 2015 CERT Cures Act changes. And there's lots of questions around, do I have to have this in place in January 23? How does it impact quality? You know, we see it referenced more with promoting interoperability. If you remember, for 2022, you had options with reporting and which, I guess, level of certification you used. You could use the 2015 CERT, or you could use the 2015 CERT Cures Act, or a combination of the both. I would be reaching out to your vendors right now and seeing where they stand with those updates and changes. And we feel like they are pretty significant for PI and may not impact quality as much. So they're probably a little more on top of the game than we think vendors are. So that's where I would be today. I'd be making a phone call to your vendor rep and saying, let me know for sure where I'm at on my certified system. And what do I need to do to get it in place sooner than later? The promoting interoperability objective updates and scoring changes, again, we felt those were pretty significant. The requirement of the prescription drug monitoring program. Most folks have that option with Casper here in Kentucky, but maybe not so much outside the state. Again, that's a yes or no, so it's not a performance-based measure, so you have to simply attest that you are querying that. But remember, you need to be able to prove it in an audit that you in fact did that prior to prescribing. And then again, they added another measure within the Health Information Exchange for TEFCA, for that Trusted Exchange Framework and Common Agreement. So it gives another option there for folks as well. Later on in the year, we'll probably have some webinars that focus on PI specifically, and we'll touch base on more of those, get a little deeper dive into those measures and objectives. Also significant was this quality measure floor removal. Alicia mentioned it in her presentation earlier. So just to recap a little bit, when we look at your benchmark scoring, we've always had a floor of 3 points, whether you submitted a measure that didn't meet whatever that benchmark floor was, you still got 3 points for it. CMS is adjusting those benchmarks. Now they start at 1 point. Now, if you're deemed a small practice, there is some flexibility there, but many of our clients are not. They're large organizations, and so this is going to be a pretty significant impact on your quality score. MVP reporting levels. Jessica really touched on that, spent a lot of time on that today. As you can see, it's very complex and could require some assistance, and so that's why you've got us at the REC to reach out to. Significant restriction within the Medicare Shared Savings Program. Lots of flexibilities were offered there, some extensions that we didn't expect to come but happened. This AIP program was pretty significant. We felt like, keep in mind that advanced payment can also be required to be paid back if you don't meet those metrics and those quality measures. But it was a good effort. CMS's ultimate goal is to move folks from traditional MIPS into APMs, and they're doing that through the use of MPPs, and then also some other incentives through the MSSP structure. And then the last thing that we talked about, which was somewhat new, but yet similar. So TEFCA is new under the PI program, and we're yet to see how that's going to play out. With this trusted exchange framework and common agreement, it's very extensive and it's broad in its definition of who's included in that. It's not just a connection to your health information exchange. It's a little more detailed, but yet also a wider net, I guess you can say, when you connect through that you can get more patient info outside of maybe certain health information exchange. And then the SAFER guide impacts. So for 2022, for SAFER guides, you had the option, to attest yes or no, and you could still submit to the promoting interoperability category. The way we're reading that for 2023 is you need to complete those high priority practice guides for clinicians. Hospitals have to complete all 9 guides. Clinics, eligible clinicians only have to complete the high priority practice guide. So that's our top takeaways. Upcoming webinars. So for February 14th, happy Valentine's Day, we'll have MIPS value pathways, understanding and identifying which pathways are right for you. This is a client-only webinar, so if you're participating with us as an REC client, you'll have an invite hopefully already on your calendar for that one. And then March 14th, this one is open to the public, and it's understanding FQHC and RH eligibility for QPP participation. We want folks to remember that just because you're designated as a federally qualified health center or a rural health clinic does not automatically exempt you from participating in the quality payment program. So as we mentioned earlier, because of the length of the content that we had today from the physician fee schedule, we really didn't think we'd have time for questions. So we are going to wrap this up, but you have our contact available for us here on the website or on the slide deck here for our personal emails. And then of course, you can reach us using our direct line or on our website or our KYREC email as well. Thank you so much for joining us. We appreciate your time.